Thank you. Good evening, dear brothers and sisters. I'm very happy to meet all of you on a very interesting webinar on an interesting topic. Though it is interesting, most often it is not discussed in the forums. So neglected topic. And today, the whole Medical Academy of India and Doc Plexus are very happy to present to you an interesting topic on osteoporosis. It's more going to be a case-based discussion. We have with us two eminent endocrinologists, two eminent women endocrinologists, one from North and one from South. They are excellent endocrinologists. They are going to discuss on the case-based discussion, and it will be like, the osteoporosis is so common, even in the pre-senile age and in the old age, as well as drug cancer, thyroids. So it's a day-to-day problem, especially for practitioners. So one should have the knowledge, what are the drugs produces osteoporosis, how to compensate, how to diagnose, and what are the problems. All those things, the case-based discussion, both the eminent endocrinologists will discuss. Dr. Minal Mohit is in charge of HOD, Diabetes and Endocrinology, Manipal Hospital, Jaipur. She is a consultant endocrinologist at Manipal Hospital, Jaipur, with experience of more than 10 years. She had done her MBBS in 1998 from JLNM Medical Center, Ajmer, and MD in 2003 from JLN Medical College, Ajmer. She has also done many fellowships, like fellowship in diabetology, endocrinology, and fellowship in pediatric and adolescent endocrinology, and fellow of Royal College of Physicians, to name a few. She has been in numerous talks and has been authored both national and international articles. And she's a very good person who is interested in research, very good human being. She has done a lot of work in IMA also. She's also the member of the IMA Hypertension Standing Committee. She was the governing council member of the ACP, and now she is the local IMA secretary, and she's also formed a metabolic endocrine unit recently. So we are very happy to have Minal Mohit. And the next speaker, again, Dr. Usha Sriram. He is a board certified endocrinologist and senior consultant endocrinologist, VHS Hospital, Chennai, and president of ISBMR. He is a physician, endocrinology and diabetes specialist, medical ethics expert, great communicator, women's health promoter, women's rights activist, founder of Divas and director of Akar Health. And Usha has been the executive committee member of the Indian Society of Bone and Mineral Research for over a decade and has held the prestigious position of as a vice president of the society. Physician education has been a core commitment for her. She has organized dozens of professional programs, the most notable being ICRDA, RE-Pro, ENDIA 2011, EndoPro, PACE 2015, TIVAS 2016. He is also a fellow of endocrinology. Both Minal and Usha are the fellows of the American College of Physicians. As I said, they both are very good communicators, both good teachers. We have done hundreds of webinars with them. They are very good in not only endocrinology, in the general medicine also. And she's also interested in public health and public problem, and especially women's health. And we are every day, every week, we are sending a newsletter called MediBeats, for which both Usha and Minal contributes in endocrinology, diabetology, and women's health care. With this, I now request the first speaker, probably Dr. Usha. I don't know, between the ladies, they have agreed something. So maybe Usha will start the discussion, followed by Minal, then again Usha, then Minal. Like that will be there. It will be very interesting. It's not didactic lecture. It will be very interesting discussion lecture. And I request all of you to post your questions. This time we don't have Kahoot because it's going to be a case-based discussion. We didn't have any opportunity to have Kahoot. But nevertheless, if you have any questions, please put it in the chat box. We will answer all your questions. Now over to Usha. Please welcome Dr. Usha. Over to Usha.
Thank you, sir. What a pleasure it is to share this space with my friend and colleague, Dr. Minal Mohit. And this topic, as president of the Indian Society for Bone and Mineral Research, I really welcome Gold Academy and Doc Plexus for paying importance to osteoporosis. And as rightly mentioned by Dr. Muruganathan, this is a very big problem. In terms of numbers, it is bigger than breast cancer, bigger than heart disease, bigger than stroke. But I'm talking about the number of hip fractures. Having said that, it is underappreciated, underdiagnosed, underreported, undertreated. So I'm so glad we are discussing it today. Let me start with the first clinical scenario. And as again, Dr. Muruganathan has said, this is going to be somewhat of informal, discussion, discussing this clinical scenario, and through that probably highlighting many of the important points that we need to keep in mind. Can I see the first slide, please? So, till the first slide comes up, I just want to say that osteoporosis, as the name itself suggests, osteo means bone, porosis means, porous means thin. So it's thin bone. And thin bones, we know, they can break easily. So the main effect of osteoporosis or impact of osteoporosis is fractures. And when someone has a fracture, the consequences are not just it's a fracture, they have to go and have surgery, and they may not be able to walk or work for a while. It's not it. The impact of fractures, especially hip fracture, is very, very serious. As much as 20% of people may die within 1 year. As much as 20-25% of people may never return to previous level of functionality. And then a significant number of people constantly need some assistance even for their normal day-to-day activities. So it has a lot of impact on life itself and quality of life. So we need to keep that in mind, and especially when someone has one fracture, their risk of having another fracture goes up considerably. So these are the things that we worry about when someone has a fracture. So I'll wait for the slide to come. And also the definition of fracture, osteoporosis has changed. We used to say, that it is low bone mass with microarchitectural deterioration, leading to bones being fragile and having fractures. So now we say osteoporosis is decreased bone strength. And this is very important to keep in mind, because bone strength is made up of bone mass and bone quality. Previously, we only talked about low bone mass. Now we are saying it is bone strength, because bone mass and bone quality. Because for the same bone mass, some people will fracture and some people will not fracture, which means the ones who fracture are having some sort of poor bone quality. And this is most apparent in people, let's say, who have diabetes. And you may actually see a slightly higher bone mass, but they actually fracture more because their bone quality is poorer. And we'll talk about that later. So can I see the slide?
Sitil, can you share the slides, please? Usha, have you given the slides to Sitil? I mean, people, organizers?
Or Minal can do that.
Yes, just a minute. I'll just share the set.
I also sent the set of slides to you. That case-based discussion slides, Sitil. Let me see. Dr. Minal?
Okay, no, sir, I'll just keep talking till the slides come up, so we don't waste any time. So that is the definition of osteoporosis. And then comes who's at risk for osteoporosis. And that's a very, very, very important thing, because unless we are aware of who's at risk, we are not going to be screening those people, and we are not going to be looking for it. So first thing we know is old age. Aging is the biggest risk factor for, okay, the slides are here. So I will discuss the first clinical scenario, which is very important, something that you would see in your practice frequently. This is a 47-year-old, I just need the name of a patient who actually came to consult me. 46-year-old Miss Vaishali consults you regarding her risk for osteoporosis and fracture. Her mother recently had a fall and hip fracture at the age of 76. So actually even 76 sounds a little bit young to me, but nevertheless 76. Miss Vaishali has a long history of acid peptic disease, but absolutely no other health problems. No diabetes, blood pressure, heart problem, kidney problem, asthma, or any other things. Her menstrual cycles are regular, which means she's premenopausal, and her BMI is 26. So for Asian Indians, that is obesity, because 23 and above is overweight, 25 and above is obesity. So she is obese. So these are the questions. So she has come to find out, do I have osteoporosis? Am I at risk for fracture? So is Vaishali at risk for osteoporosis and fracture? Should she undergo any assessment of her vitamin D and calcium status? Should she have a bone density test? And what can she do to lower her risk for osteoporosis and fracture? So if we answer these questions itself, I think in terms of a lot of how we practice in our clinic, I think we will know what exactly should be done. So the first question is Vaishali at risk for osteoporosis and fractures? So her mother had hip fracture and osteoporosis, so definitely that puts her at risk, because maternal history or family history of hip fracture is a big risk factor. And does she have any other risk factors? She's premenopausal. She's only 46. She is, slightly, mildly obese. And then we can discuss, is obesity a risk factor for osteoporosis? Traditionally, we always thought that thin stature is risk factor for osteoporosis. But a lot of evidence is emerging that being obese is also a risk factor for osteoporosis. In fact, there is a very nice paper by Clifford Rosen that talks about, is obesity is osteoporosis the obesity of bone? Meaning that if somebody is obese, they may actually have more marrow fat, they may have obesity-driven cytokines that may be unhealthy to the bone, and the obesity itself may actually interfere with people's measurement of bone density. Also, their vitamin D may be low in people with obesity. So you see there are problems with being obese and the bone. But her BMI is 26, so something to keep in mind. But there is one other thing in her history that I would definitely sit up and take notice, and that is the use of PPIs. So she has acid peptic disease, and she's been taking proton pump inhibitors for a long time. And people who take proton pump inhibitors, we know because of the acid, the complete decrease in acid and their absorption of calcium and other reasons, they may be at risk for bone loss. So that is another risk she has. So is she at risk for osteoporosis and fracture? Definitely she is. Should she undergo any assessment of vitamin D and calcium status? The answer is yes, because I would definitely take a history from her many people who have acid-peptic disease either take too much milk or they cut out milk and things like that. So I would go into a history and find out if her dairy intake, dairy and greens and dals and all that are the sources of calcium. And I would also find out whether she's vegetarian, because vegetarian food has no vitamin D. And what about sun exposure? I would find those things out. And if there is any evidence of that she potentially could be having a problem with vitamin D deficiency, or if she complains to us of aches and pains, which she didn't, but I would definitely ask. So at this point, I also want to say, osteoporosis is typically painless. The only pain we have is when we fracture a bone, or if there have been micro fractures or something people can have, especially with spine fracture, they can have back pain. But if a painful bone is osteomalacia, which is from vitamin D deficiency, and osteo is bone and malacia is soft. So it's a soft bone that is more painful and not the osteoporotic bone. So that's something about aches and pains, about muscle cramps, proximal muscle weakness, generalized fatigue. Those are all things I would ask in the history, and then think about measuring the vitamin D status. And I usually do not replace women who in the premenopausal years with calcium unless they're on some diet that is deficient in calcium. Should she have a bone density test? So the recommendation by North and IOF and others is to do a bone density for women at the age of 65 and for men at the age of 70. Definitely that looks too late for our people, because it looks like the people from India and other South Asian countries and Asian countries may be having fractures and osteoporosis about 10 years earlier. So what we would like to recommend, and what I do in my practice, is I do a bone density for women at age 55 or 5 years after menopause, whichever comes first. And for men, I do it after the age of 60, so that that 10-year gap is corrected by doing it earlier. So that is how I do it. And she is 46, so we really don't have to do a bone density test for her. But definitely I would do it for her at 55 or 5 years after the menopause. And what can she do to lower her risk for osteoporosis? So I think we should tell her, you are at risk for osteoporosis because your mother, and because you're taking PPIs, and because you are a little overweight, and therefore we should talk to her about how she can get calcium in her diet, how she can get vitamin D from the sun, and how she can do weight-bearing exercises with the muscle. And one thing that has been established well is muscle correlates with bone strength. Therefore, that's why men have higher bone density, not because of testosterone, but because of the muscle. And the same thing for women, if they can do weight-bearing exercises and build up their muscle strength, their bone density is going to be better. And of course, optimization of vitamin D status is very, very important. Bringing keeping the weight optimized is also helpful. So these are the ways I would look at this first patient. And two important points to keep in mind are, we don't want to be doing bone density tests on women too early, because again, when you do it very early before age 35, we are only comparing them with 30-year-old sex match 30-year-old women. So sometimes they will come back as a low level. And we should also, for premenopausal women, if you do a bone density, you should look at Z scores and not at T scores. We can discuss that also later. So I'll let Muruganathan.
Yeah, thank you, Usha. there is no role for moderator now because you yourself asked the question, you answered all the common questions. Anyway, I'll come back to you later after second case. Now I request Minal to present her case. Minal. You unmute, please, Minal.
Kindly allow me to share the screen, please.
Yes.
Yeah. So my screen is visible, I believe.
Yes, yes.
So taking up from ma'am has beautifully presented a case of a lady who already fractured her bone, and so the daughter is worried about herself. So taking up from there, probably that old lady who fractured her bone came to me actually. So we'll talk about that fractured lady now. So osteoporosis in elderly. So this was a 70-year-old lady. She had a low BMI. She was only 19 kilogram per meter square with not a medical history of significance, but she had a history of a fall in the washroom, which led to a fracture of her femur, neck femur, that right side. So this woman, now to begin with, to define osteoporosis, ma'am has already told us it's not only about the bone mass, but the quality of the bone. So it is the decreased bone mass as well as there is a decreased quality because the bone is a dynamic tissue always under remodeling. So the imbalance between the osteoclastic and the osteoblastic activities actually lead to osteoporotic bones. So we have a lot of causes, the predisposing factors where we need to work out which women should have more attention maybe, or which men should have more attention, because even men do have osteoporosis. So there are genetic factors, as this lady, the young woman, because she had her mother has osteoporosis, also has a fracture bone now. So then genetics plays a role. Then of course hormones and the vitamin and calcium minerals, they do play a role. Then the BMI plays a role, and the comorbidities in terms of specifically hyperthyroid and hyperparathyroidism plays a role. Short duration of reproductive cycle. Yes, the women hormone, the estrogens are protective hormones for most of our complications. So a woman who's having a short reproductive period will have increased predisposition of osteoporosis. Then the comorbidities like rheumatoid arthritis, this will be my second case, because these are the comorbidities which make the patient take drugs which predispose them to osteoporosis, like steroids. Then the extrinsic factors, as we re-emphasize the nutritional intake, the adequate intake of calcium, vitamin D, maybe the negative factors like alcohol and smoking and sedentary lifestyle. Then drugs, yes, as PPI, the proton pump inhibitors, madam mentioned, and also steroids, which are the most common cause of drug-induced osteoporosis. So these are the causes of osteoporosis. Now the impact, as we talk of, we find that yes, any fracture will decrease life expectancy, because most of these patients, they are already old, weak, and they do not come back to the normal life again anytime. The healing is not perfect at times. And you will see that almost osteoporosis is responsible for almost 30% of the fragility fractures, and out of which 60% are the hip fractures. So this is the most common cause of hip fractures in women especially. The most available method for assessment of osteoporosis is DEXA scan, that is dual energy X-ray absorptiometry. We do it commonly at 3 sites, that is the neck femur, the lumbar spine, and the wrist. And depending upon the T-scores and the Z-scores, as we will discuss later maybe, the T-score compares you or your reports with a younger population, whereas the Z-scores or the Z-scores, as you call them, they compare you with the same age and sex matched population. So Z-scores are more for the coexisting comorbidities, and T-scores are your age-related or the senile scoring. So other than the DEXA scan, we do have some clinical calculators available, like the FRAX scoring, which can be used. You can have these from accessible through your Google or internet. And if the FRAX score is giving you a 10-year probability of hip fracture that is 3% or higher, or a 10-year probability of major osteoporotic fracture of 20% or higher, you need to intervene. So FRAX can be combined with BMD, that is the DEXA scan, or FRAX can be taken into consideration even without BMD, that is without DEXA scan. Another calculator which is available, which can be used through Google, is the Garvan's Institute Fracture Risk Calculator. So this is using 5 factors into consideration. So using these calculators, you can assess which patient needs how much intervention in terms of management. So besides this, as ma'am was also repeatedly saying, that we also need a strong muscle mass, because a bone will only break once we fall. So we also need to prevent the falls. So we also need a strong muscle mass to prevent falls, so that we can also prevent fractures. So we have to also assess the risk assessment, the fall risk assessment, like the socio-economic background, the surroundings of the patient, whether the patient is using steps frequently, whether the patient is having visual impairment, the audibility factors, because old age also brings all these complications along with it, that the patients are not able to sometimes see properly or hear properly, and they are more prone to falls. So we have to also train them for exercise, that is muscle strengthening is part of it, and hip protectors can also be used at least to prevent the hip fractures. Then comes the role of pharmacological management. Pharmacological management comes in terms of nutritional replacement, in terms of calcium and vitamin D optimization. Then after the calcium and vitamin D optimization, we also have some interventions like the bisphosphonates, we have the teriparatides, we have denosumab, we have strontium ranelate. So we have a number of drugs available with us where we can use to manage such patients. Now there is something called integrated care for the older population or the older persons. This is just one assessment where you can assess the older population, where you look into the need of the patient, like how much is the need for exercise training maybe, or the hip protectors maybe. And then of course, if the DEXA is giving you osteoporosis also, then how much is the need to treat the patient. So we have a lot of data, a lot of studies available, which gives us which intervention is going to help you how much. So calcium and vitamin D actually plays a very important role in the primary prevention also. Then we have bisphosphonates, which are available as oral once a week therapy, alendronate and risendronate. We also have IV therapies yearly, like abandronate and zoledronate. We also have the anabolic hormones teriparatide, and we also have the antibodies, that is denosumab, the monoclonal human antibodies, the denosumab. So these are the injectables, teriparatide and denosumab, and teriparatide, out of which is the anabolic hormone, which also helps in rebuilding the lost bone strength. So calcium deficiency and calcium and vitamin deficiency, they do accelerate bone resorption and promote osteoporosis. So we need to take care right from beginning. The recommended daily intake for calcium is around 1 gram to 1200 milligrams. Vitamin D intake has to be around 800 IU per day. So vitamin D supplements are required as 800 IU per day. Alendronate, there are a lot of studies which suggest that these are the bisphosphonate group of drugs which help more in preventing or re-strengthening the vertebral structure. And they do have, though we don't have much evidence for the non-vertebral or the hip fractures, but they do help in strengthening the vertebral fractures at least. Similarly, we have data with risendronate. We have data with zoledronic acid, which is used once a year. We also have drugs like clodronate and raloxifene. Raloxifene are specifically used for postmenopausal women where other molecules are not very effective or not tolerated. Strontium ranelate is another mineral which is once a day therapy, oral. Coming to the most important molecule, that is the teriparatide, which is used especially when the woman is having fractures already. This is the injectable therapy, subcutaneously given. This is an anabolic hormone, which is the parathyroid hormone, actually, the 1 to 34 amino acid structure taking. This molecule is the molecule which is going to re-strengthen or rebuild the lost bone. Duration of therapy, yes, it needs to be taken at least from 6 months to 2 years. Denosumab is a newer molecule which is available, which is again given once in 6 months, subcute injectable therapy. Now, how do we assess whether these therapies are working or should we stop treating our patients? So if after the therapies also, you find that on a repeat bone BMD scan, the DEXA scan, you find that the DEXA strength is not building up, rather it is decreasing, then it is an indicator that the treatment or the therapies are actually not working or failing. So we do not need to continue the same therapy. So in such a case, either we escalate the therapy to anabolic hormone or the more intensive therapy. So the success and failure depends upon the adherence and the compliance. Suppose there is no new fractures, the BMD has increased. There are also some bone markers, though they are not very easily available in most of the labs or all of the labs. But there are bone markers which tell you for the bone resorption markers and the bone building markers also. So we can assess the bone markers also. But if the fracture risk has been attenuated, then that means that the treatment should be maintained. Adherence is very important in all such therapies because all of them are long-term therapies. We need them from 2 years to even 10 years. And when everything else fails, then of course we need to build up the therapy. As I was talking, we can go for higher or more intensive therapies. Physical activity training is most important. We have to, besides all, right from beginning. Maybe 70 would be a little late to intervene. So physical activity training needs to begin right from early stages and early years of life. And there have been a lot of studies comparing various physical activities, the level of interventions, and the most recommended is that at least 60 minutes of exercise 2 to 3 times a week for more than 7 months is going to give you good results in terms of bone strength. So just to conclude that physical activity is important. You need a good calcium intake, a vitamin D intake, and a regular physical activity, and preventing falls is also equally important to prevent fractures. So this is about my case of senility and senility osteoporosis and how to prevent the falls and prevent fractures and how to rebuild or give a primary prevention. And if the bone is already weak, how to give a secondary prevention. Thank you.
Thank you, Dr. Minal, for enlightening about the management, especially the elderly people. Of course, I'm very happy there are already 10 questions in the chat box. I think by the time you finish the cases, I think we'll have more questions. So I have no role to do anything because I'll have to just ask the questions from the chat box. Usha, now for the second question, what are the drugs that can produce osteoporosis? Especially cancer drugs. Your second case.
Okay, second case.
Can you share the slide, Minal, for Usha?
Yeah, sure, sir.
Yeah, please. The second case scenario. This is yours, Minal.
Yeah. Just a second, sir. Just give me a second, sir.
In the meantime, Usha, what is the relationship with Bioglycosome and osteoporosis? You should not give Bioglycosome for an osteoporosis patient because of the fear of bone fracture, especially post-menopausal women and diabetics. Can Bioglycosome itself can produce osteoporosis?
Yes. See, what happens is the same cell differentiates into the fat-forming cell and the bone-forming cell. So when you use drugs like PZDs, right, it takes the fat-forming cells.
Okay.
And not the bone-forming cells. So that is one of the main mechanisms of the mesenchymal stem cell. When it differentiates, it will go into the fat-forming cell, into an adipocyte, as opposed to the bone-forming cell, which is the real reason why they develop bone loss. So for women using PZDs, this is the biggest, one of the bigger risks. I mean, there are other things with PZDs, but this is a very, very big risk.
Okay.
So
now your case is your second case has come.
A 56-year-old lady with a history of breast cancer, diagnosed at 43. We know that breast cancer is the commonest cancer, both in postmenopausal women and in premenopausal women. Her cancer was estrogen receptor positive, which is, by the way, the most frequent type of breast cancer. And she underwent, which means that the cancer is responsive to estrogen. And then she underwent total abdominal hysterectomy, bilateral sulfidophorectomy. She was also started on, anastrozole, which is an aromatase inhibitor. Again, something that completely wipes out the estrogen post surgery. So here is a lady who, at the age of 43, has undergone undergone a hysterectomy with oophorectomy. So her menopause has happened, which is also early, and she's also on aromatase inhibitor. Next slide, please. And she's only 56.
Next, yeah.
So she went a BMD assessment as part of her master health checkup, and as I mentioned earlier, typically she should have had a master checkup in bone density because she's 5 years post-menopausal. She had menopause at age 43, and now she's 56. So either it is 55 or 5 years after menopause. And then in certain medical, we may have to individualize and do it earlier. And underwent master checkup, but very surprised to find severe osteoporosis in a 56-year-old. So she has a family history of breast cancer, which may explain her risk for why she got breast cancer, one of them. Her BMI is 31, and I mentioned even in the first clinical scenario that obesity has multiple effects at the level of the bone, and it is something to keep in mind. And then there is also, like I said, question that is someone overweight or obese because they are less physically active and they are less outdoors, and maybe they've got less vitamin D, they are less physically active, they have less muscle and more fat. So that is also maybe playing a part. And she has type 2 diabetes at the age of 40. So now it's 16 years of type 2 diabetes, and she's on metformin, vildagliptin, and dapagliflozin. So to answer Dr. Muruganathan's question, luckily she's not on PZB, Pio or Rosie or any of them. So that rules out, that as a cause of or contributing to the osteoporosis. One of the things, can we go to the next slide? So, when evaluating this patient with such severe osteoporosis, is breast cancer a risk factor for bone loss? It's something that we should, think about. And we know that, cancers have, when someone has a cancer, they may have nutritional problems, they may be on medications that cause it, they may have metastases to the bone, they may have, other causes that are leading to bone loss. So, directly the breast cancer, except maybe metastases, maybe the medications that are used for the cancer, all of these we have to seriously consider, or a nutritional factor as well. Then, which of our medications could lead to bone loss? So, metformin does not cause bone loss, we know that. The gliptins do not cause bone loss. If anything, there may be a small salutary effect on the bone, so that doesn't do that. What about dapagliflozin? Right after the initial Canva studies and the canagliflozin studies, we heard about fractures that happened, and there was a lot of uproar about SGLT2 induced fractures, and a lot of theories were floated around. But one of the things that I think finally emerged was it's not likely to be due to the drug itself, because we did not see that with empagliflozin studies, did not see that with the real world DAPA studies, and even with CANA, what it showed was that it was upper arm fractures that were more common, and it happened very quickly after initiating, maybe within a few months. And we all know that bone loss to that extent and fractures do not happen in such a short time. So one of the theories is possibly there was some degree of some dizziness or a slight dehydration from use of the SGLT2 inhibitors and falls, which could have caused the upper arm bone loss. Though there are many other theories that were put forward for canopy frozen. Subsequent studies have not panned out to support the SGLT2 bone loss theory. So I think we don't have to worry too much about that. So in her case, which medication led to bone loss? I would put the blame on many things like the anastrozole for sure, and then possibly, and I know Minal's going to talk about this after this, you know, when she was undergoing some chemotherapy cycles, it's possible that she was given some steroids, and that might have contributed some to this as well. And then, of course, nutrition deficiencies. Then comes this very, very important question. Is diabetes a risk factor for osteoporosis? So, sir, at the end of this program, if from my side, if I'm able to give one point, that is, diabetes is a huge risk factor for osteoporosis and fractures, that we should consider osteoporosis as a complication of diabetes. And it is more in women. The INDIAB study has shown that fractures are already more in women. When they have diabetes, it's even more, much higher for type 1 and high in type 2 also. I mean, that's a paradox because the bone density is a little more, bone mass is a little more in people who have type 2 diabetes because of insulin resistance. And obesity also, we always thought they had a little more bone. But then I mentioned right in the beginning about bone quality. So people with diabetes have poor bone quality. The duration of diabetes matters. The control of diabetes, the higher the A1C, greater their risk. And they may also have other things to do with the cortical porosity and other bone quality that seems to be a real problem. Then there is another side to diabetes, which is they may have eye problems. They may have problems with their neuropathy and feeling things. They may have dizziness due to hypoglycemia. They may have PIAs. They may have multiple reasons for falling down. And then we also know that many people with diabetes have sarcopenia. So that may also be contributing in a way to the bone loss in diabetes. So it's a huge risk factor for osteoporosis. And one of two ways to think of it, if you do a bone density, when you see a person with diabetes, what you should do is subtract another half SD, meaning you get back the report as minus 2.4. It's actually minus 2.9. Or you got a minus 3. It's actually a minus 3.5. So make the correction. And suppose you're doing a FRAX score. In FRAX there is no diabetes in that list. There's rheumatoid arthritis, there's family history of hip fracture, steroid use and all that, but no diabetes. So what they're saying is substitute rheumatoid arthritis for diabetes in the FRAX scoring, then you'll get the real score. So all these things have to be done for people with diabetes, but then ultimately you treat them just like people with osteoporosis and fractures. And I already this high BMI being a risk factor for osteoporosis, which is why this 56-year-old young woman, very young person, has got such a bad bone because on the one side cancer treatment, diabetes, obesity, all are one on top of the other to make her so osteoporotic.
Thank you, Dr. Usha. I'll come to you with a lot of questions, but one drive home message you have clearly given to all the people who are watching. Diabetes is a risk factor for osteoporosis. What are the ways osteoporosis happens in a diabetic patient? You already enumerated, but the point here is any diabetic patient, especially women, definitely look for osteoporosis. That is a good message from Usha. Now we'll go to Minal. Yes, Minal, the second case. how steroids can produce osteoporosis. That's the case I think Vinal will present now. Because day in and day out now we use steroids quite frequently. So you must watch for osteoporosis, especially when you are giving steroids for prolonged period. Vinal? Yeah, you are. Please unmute.
Yeah. So that was really nice hearing ma'am again. And in case now, so I'll just give me one.
I'm sorry, Minal. You said it's nice hearing me, Usha again, but not me.
Oh my God.
Okay, go ahead, Minal.
So,
Share your slides, Minal.
just give me a second, sir. This is.
Enough to know that you and I had a long 30-minute conversation this morning, and then you'd say, oh, you didn't talk to me.
No, the idea is, sir, we still need to hear. Your will be the final closing comments, and I'm very sure I know I have the best experience with you already, that you will have the last word, I know.
No, but in this case, please, Minal, forgive me, because I am the moderator. I will have to give you the last word, not Usha.
Yes.
Yeah, correct, Usha? Usha, you were saying about the BMI. The less BMI also is a risk factor for osteoporosis.
Low BMI is a very big risk factor.
Because in your question, you didn't you mentioned only about the high BMI.
So yeah, because madam skipped that, because I had covered that my patient was a low BMI patient.
Okay.
So actually, the extremes of BMI, both sides, it is going to affect the bones. In some other ways, the underlying mechanism is different, but we need ideal BMI for a healthy bones, just like for all other systems.
Okay, go ahead.
So with your permission, sir.
Please.
Now this is my second case. Now this time we are talking of a young female, 58 years old female. She has a history of rheumatoid arthritis, and she has been on prednisolone 10 milligrams OD started for the past 10 months only now. So why I have taken this particular case, because there's a short duration, just the beginning. So we would like to highlight that can steroid-induced osteoporosis be prevented if we are aware about it? So now she is worried for the side effects of steroids, and besides the other side effects, we are worried about her bones. So beginning with the topic right now. So osteoporosis we have already defined, and steroids are one of the most common cause of secondary osteoporosis or the drug-induced osteoporosis. And most of the glucocorticoids, they may be used for short-term or long-term. They definitely affect the bone health. How do the glucocorticoids affect the bone health? Right from the misconception is that they increase the osteoclastic activity, that is the bone resorption. But it is actually the other way around. They decrease the bone formation. As I told you earlier also in the first lecture, that bone is a dynamic tissue always undergoing remodeling. So glucocorticoids actually stop that remodeling. So the new bone formation is stopped. Also, there is increased resorption. I'm not saying it is not there, but the mechanism underlying to begin with is that glucocorticoids actually stop the new bone formation first. So there is increased apoptosis also mediated by the rank ligand method. Also, there is a pathway which is inhibited, that is the WNT signaling pathway which is inhibited. Then there is activation of the PPAR gamma-2 pathway also. So put together, there is again an imbalance of the osteoclastic and the osteoblastic activities, leading to decreased bone formation and also hampering the bone quality. At the same time, there are neuroendocrine systems involved because of aging. At this age, there is menopause around, so there is a decreased estrogen, decreased testosterone mass. The androgens are already less on the lesser side, so they also affect your bone strength. Then, of course, the calcium metabolism, because of the long-standing decreased calcium levels in the body, decreased absorption again because of aging maybe. There is increased loss of calcium in urine, so there is decreased serum calcium. There is secondary hyperpara, which also contributes to decreased bone strength. Then the muscle system, as madam also said, we are also dealing with sarcopenic population, older population, perimenopausal or postmenopausal population on steroids long term. So that also causes muscle weakness, also contributing to myopathies and increasing the risk of fall. So put together, this algorithm takes us to steroid usage increases the risk of bone fractures. So which are the group of population at higher risk of steroid-induced osteoporosis? Low BMI to begin with. Parental history of hip fractures. Patients currently smoking or long-standing history of smoking. Alcohol intake. Higher the dose of glucocorticoids, lower the duration of glucocorticoids, higher is the cumulative glucocorticoids, IV pulse glucocorticoids, and of course the central bone mineral density is the most which is badly affected. Etiopathogenesis we have already discussed. It is affecting all the pathways. So the fracture risk is increased. Almost 30 to 50% of the steroid-induced, steroid-administered patients experience a fracture and a fall. So there's a positive correlation with the cumulative doses, as we discussed, the duration of the steroids and the dose of the steroids. Interestingly, the initial fall is very high. So the initial rapid fall is in the first 3 to 6 months. So primary prevention, that is why my case is saying that this has been just 10 months of therapy now. So the initial attention to the patient is very, very important, because the initial fall is very fast. Then it does stabilize, and then again in the later stage, when it is chronic use or utilization of glucocorticoids, maybe again the bone loss becomes very high. So the fracture risk categories in the glucocorticoids, if you look at, this is again age dependent. So younger population does take it a little better, but older population is taking it very badly. So there are higher risk of fractures, especially the patients with a prior history of fractures, especially the low BMD scoring. So with FRAX scoring, maybe you can assess. So BMD combined with FRAX and also a history of fracture and a patient above 40, they are at very high risk of glucocorticoid-induced fractures. So we always go for the initial risk assessment. So initial risk assessment begins with the duration and the age. So if it is a children age group, maybe you can avoid further assessment. If it is younger age population with no further risk factors like a family history, the genetic background, a history of osteoporotic fractures, an ideal BMI, no other risk factors, you may not go for BMD assessment. But if it is a high risk group, you need a BMD in the initial 6 months of glucocorticoid treatment. If it is an older population, then yes, you have to go for a BMD screening right in the initial period, that is the first 6 months. Again, if the usage of glucocorticoid has been a chronic one, that is more than a year. Again, for the children, maybe you do not have BMD scoring, we just do not go for a DEXA scan in children. Probably we do not have the standardizations also available. The T scores and the Z scores are for 25 years of age, so we do not have comparative data. Maybe ma'am can enlighten me further with these details. With the younger population, again, depending upon the past history, we will not go for a BMD, but with high risk factors and in the older population, we always go for a BMD scoring. So glucocorticoid effects on muscles and bones. Glucocorticoids are the catabolic molecules, catabolic steroids basically. So they do cause myopathies also, they cause muscle atrophies, muscle weakness, they increase your bone weakness also. So glucocorticoids affect not only bones, but also muscles. As a result, this algorithm probably we've seen earlier also. So what are the recommendations? Now, these are the standardized international recommendations for population on glucocorticoids, that is glucocorticoid-induced osteoporosis. What are the recommendations for prevention? So the preventions are the primary prevention, that is all population. We have a difference of opinion among the American guidelines and the European guidelines here. But to be very brief, all population should be given the benefit of calcium and vitamin D as a part of primary prevention in the optimal therapy. And as a part of low risk group, nothing more to be done. But as a part of high risk or moderate to high risk group, in the younger population, we go for BMD scoring. And if there is osteoporosis, we do give them the benefit of bisphosphonates. In the older population, if there is BMD scoring suggestive of osteoporosis, or it is already a history of fracture, we can give them bisphosphonates, as well as we can also give them teriparatide or denosumab. So these are the preventive strategies going by the American guidelines and the European guidelines. So the idea is prophylaxis and treatment. Prophylaxis by calcium and vitamin D. Dosage recommendations are calcium 1 gram and vitamin D 800 IU per day. Preferably, when we are using glucocorticoids, one line of recommendation is that you should be using the active form of vitamin D, Not the cholecalciferol, rather we can go with alpha-calcidiol or calcitriol. Then, of course, one more important point here is that if the patient is having hypogonadism, then hormonal treatment is the therapy of choice, not alone bisphosphonates and not alone the calcium and vitamin D. Bisphosphonates do play a role, but in case of hypogonad population, we also require a hormone replacements. So coming to the American Society and the European Society comparison, as I was talking, steroid dose, any dose, especially more than 5 milligrams a day for more than 3 months, or any dose more than 3 months, all patients should be given the benefit of primary prevention. All patients should be given the benefit of calcium and vitamin D, whereas the European guidelines say that all patients above 65 or all patients with nutritionally already deprived should only be given the calcium and vitamin D. So going by more generalization, probably we would prefer keeping all our patients on calcium and vitamin D supplementations if they are on steroids. Bisphosphonates, just a word here, because bisphosphonates are the drugs for treatment, the first line treatment after calcium and vitamin D, which are more for primary prevention. When we talk of therapeutics, the first line drugs are bisphosphonates, and bisphosphonates, as I have already discussed in the first session also, we have weekly therapies, we have yearly therapies, we have oral therapies, and we have IV therapies also. So we have drugs these are the bisphosphonates which are recommended for at least 2 years, and they do have a preventive role in preventing fractures. And patients already having osteoporosis should be given the benefits of bisphosphonates. The steroid population, the various drugs available, bisphosphonates, alendronate, we can use it once a week, oral therapy, etidronate, risedronate, or zolendronate, which is 5 milligrams once a year, IV therapy. Then, of course, we have the anabolic hormone, that is teriparatide, which is 20 micrograms every day, subcute, for more than 2 years, around 2 years maybe. Then we also have other forms of trial therapies, not really proven so far, but we do use at times calcitonin, especially for bone pains, it has very good role. We have hormonal therapies, estrogens, HRTs are given at times. We also have fluorine at times recommended, strontium is recommended, strontium ranelate, not the plain strontium maybe. Then steroid treated women, we also need to increase the BMD in the lumbar spine, and the lumbar spine has been, most of these drugs have been shown to have effect in the vertebral column or the central bone mineral strengthening maybe. So the idea approach when the patient is on chronic steroid therapies, primary prophylaxis, bisphosphonates as first line therapy, and also continuing the supplementation with calcium and vitamin D. So important approaches are to, most important approach is preventive here again, that is how to avoid the corticosteroid or the glucocorticoid induced osteoporosis. Use the minimum dose that is required and use it for the minimum duration that is required. Most of the patients who are on doses below 5 milligram are not that badly hit, but if the patient is on more than 10 milligrams a day and for more than 3 months, then osteoporosis is more likely to happen. And if the patient is probably because of the comorbid conditions recommended steroids for of the higher doses and longer duration, then primary prevention is something that we always need to offer to our patients. So this is the standard algorithm, that how do we go about it, with what BMD, the first line therapies, the second line treatments, for the prevention of bone loss, the bisphosphonates, and of course the treatment comes with your either IV bisphosphonates or with teriparatide. We have to repeat the BMD in 12 months, again assess whether the therapy is failing. We can escalate the therapy if the therapy is failing. So to conclude, osteoporosis is one of the major limitations of steroid usage. We have a high risk group which is on osteoporosis, which is facing osteoporosis because of steroids, and we can always go for primary prevention. Yes, steroid induced osteoporosis can be prevented, can be delayed, and fractures definitely can be prevented by preventing fall and muscle strengthening. I think that's all for the today's 2 cases. Thank you so much.
Thank you, Minal. I think I congratulate both eminent endocrinologists for their excellent presentation. In the 4 cases, you have covered almost all the points of osteoporosis. Very nice and very good. And as usual, Usha and Minal rocked in the discussion. Now, let me ask questions from Usha. Usha, tell me how to prevent osteoporosis in a diabetic patient. See, you have said a very, very important point. Diabetes is a risk factor for osteoporosis. So many people, like 70 million people are there with diabetes. So how do you prevent osteoporosis in a diabetic patient, both male and female, and particularly with respect to the diet? What sort of diet they should take? Should they take vitamin D and calcium as a routine? In a diabetic patient, do you advise in the master health checkup BMD also?
Okay. So, how do we prevent, and the point that you made, there are 70 million people with diabetes, or we've increased it to 80 recently. So 80 million people. So I look at it as a great opportunity, like low-hanging fruit. Even if we take these 80 million people and pay attention to their bone health and prevent fractures, that's a big service we have done to people. So many things, keeping their diabetes under good control. Obviously, we can't do anything about number of years, but A1C under better control, making sure we avoid agents like PBDs, and making sure that their diet is high in protein. See, what happens to a lot of people with diabetes is they're struggling with this, how much protein to have, how much fat to have, and because they have to eat a low carb diet. So a decent amount of protein, somewhere around, a minimum of, I think 20-25% of protein should be there in the total calories. And if they can take a little bit more than 30%, it would be even better. So that is very important. And good quality protein is very important. If they are eating non-vegetarian food, then egg whites and fish and chicken, it also has other kind of benefits. And then next thing is foods that are rich in calcium. So as a routine, I use only 500 milligrams of calcium once a day for replacement, supplementation. The rest should come from their diet. It's also better absorbed. Milk, curds, that will also provide protein, and greens and dals, which will provide protein. So this is how they should get the calcium. And the vitamin D, unfortunately, there is zero food source in vegetarian food. They only have to get it from the sun. And in the sunlight, they have to get it between 10 in the morning and 4 in the afternoon, and not an early morning sun or a late evening sun. Then there is no vitamin D in that. Now, you asked the question, should all people with diabetes routinely get bone density as part of their... So they should get a bone density, definitely, as baseline. If it is very, very good, then we don't have to do it every year. Then we can wait for 2 to 5 years to repeat the bone density. If it is osteopenic, then I would repeat it in 2 years. If it is absolutely normal and good, then I would wait another 5 years, because that's how long it takes for it to reach osteopenic range or osteoporotic range. And of course, give a lot of fall prevention advice. But if you see the osteopenia, remember I said you must add half SD. So make that correction and then calculate the BMD and treat that with the bisphosphonate. I've stopped using oral bisphosphonates. I'm using only either IV bisphosphonate or a subcutaneous. In osteoporosis management, it's become very easy actually. There are only 3 drugs we can use available in India: bisphosphonate, teriparatide, and denosumab. We don't use any of the. We don't use estrogen for osteoporosis. We do use it in women who are premature menopause or very early menopause, up to the age of natural menopause, but not beyond that. And we don't use, we use the selective estrogen receptor modulator like Bioglycosome. I use it only in that rare breast cancer person who has, let's say, only spine osteoporosis, and I want to use a agent like that. But otherwise, I give bisphosphonate. And should you give them all, vitamin D? I really think that we can give it once a month, 60,000 or 2,000 a day for everyone with 500 of calcium a day. But most important, like you said, check the bone density or do the fracts. Keep bone density, osteoporosis, like do eye exam or check kidneys. keep also the bone health.
Yeah, thank you, Usha. You have covered almost all the points related to diabetes. Of course, adding to whatever you said, exercise is also very important in a diabetic patient for preventing osteoporosis. That's the only point which I think you omitted for me to add. Thanks, Minal. Now, you were saying in the slide 3 important words to remember, but you did not mention those 3 words. Please, mention those 3 words I saw in the slide. What are those 3 words? You said some door, diet.
3 words.
Yeah.
Sorry, 3 words regarding what, sir?
It is there in the slide, in your slide. You says, please remember these 3 words. And this was says door, diet, or something like that. 3 words. You can go back to your slide and see. So you did not mention, but you said you must remember those 3 words. So I thought you should repeat it. Okay, you forgot
I don't know, sir.
Yeah, but
Maybe I
in your slide, saw there were 3 words.
The first session or the second one?
The first session. It was
First was
there.
the senile induced osteoporosis.
You're given the intrinsic and the extrinsic factors. You see, that time you're given these 3 words. You remember, and you're given 3 points. Something like door, diet. Anyway, okay. You can go back after I talk to Usha. You can find out and come back to me. Now your scores. You have given me so many scores. See, tell me as a physician what particular score we can follow. Of course, BMD is the standard. But you are given a FRAC score, this score,
yeah.
score, Usha score. We know so many scores. I don't want please give me simplified scores which we can use.
The gold standard still remains the DEXA scan only. So we do, if you need to treat a patient with where you can measure measurable parameters, then we go for a DEXA scan as the baseline before we start a treatment, and then we can follow up with a DEXA scan. But the patient, if the DEXA is not available and you want to do a clinical assessment, then we go by a FRAC scoring. So FRAC score calculators are available. You can download it from the Google anytime. They have particular parameters. You have to just fit in the formula, the age, sex, BMI, and your history, maybe the history of rheumatoid arthritis or something. There are few parameters. You just feed in, and you can calculate the FRAC scoring. That also gives you the percentage probability of the hip fracture and the probability of the major osteoporotic fracture in the next 10 years. So depending upon that's a clinical parameters.
So clinical parameter, FRAC score is the best score, because the other score which you have mentioned, something like starting with CO or something, that score, I didn't.
The Gorman fracture,
yeah. That's not very important.
That also can be used. That also uses some 5 parameters, but more important, more of the emphasis is always, which is universally, internationally accepted, is the FRAC scoring.
Okay, fine. Now we'll ask only short questions now. Yeah, I'll come back to you. What is the difference between rickets and osteoporosis?
Oh, rickets is childhood osteomalacia. So it is a soft bone from vitamin D deficiency. Osteoporosis is thin bone, which typically happens in older people, and so that's very big difference. One is due to vitamin D deficiency, one is due to bone loss or bone quality and thinning of the bone.
Okay, and Minal was saying you cannot use BMD in children. Is it so? There is no score, standardization in children.
So there's a software, sir. I think so. There's a software for children that we use, and also we usually use the Z score, because the peak bone mass is reached only in the late teens or early 20s. So if you take children, they have not yet reached their peak bone mass also. So their bone density will look very, very low. So we use the Z score, and then we also have software for children.
Okay, for rickets, do you have any specific bone scan or any specific things like imaging?
X-ray will show the metaphysis and the whole very classic X-ray. You can see by very classic picture on the X-ray.
And what is the 2 different scores, Z score and the T score?
So T score is what we use in adults, and that is the WHO definition of osteoporosis.
Okay.
So T score is comparing suppose you take a 70-year-old woman, she will be compared with a 30-year-old woman. Z score is, she will be compared with a 70-year-old woman. Age and sex match. He is 30-year-old, but sex match. So so if you take a 70-year-old woman and match her with another 70-year-old woman, they both should be identical, no? Because the age factor is now.
Yeah.
So if you find this lady's numbers are really, really poor, right? Then you know that compared to the age, her numbers are very bad. On the other hand, if you find the Z scores are poor, so then some secondary osteoporosis is going on. So that gives us some clue or possibility of, is it just regular osteoporosis or possibility of secondary osteoporosis.
Okay. Minal, before I go to the chat box, did you find out that 3 words?
No, I was scrolling through my slides.
Okay, doesn't matter.
Get it, sir.
Okay, we'll ask you later. Now we'll go to the chat. No, we'll go to the chat. Go to the chat box, and then we have got so many questions now, so we can always come back. Calcium supplement can cause vascular calcification. Is it true? Sarita Desai. See, we now talk about coronary calcium score and all that. So, imaginarily, suppose if we give too much of calcium, will it increase coronary problem? Usha, you can answer.
So, I want to say the jury is still out on that. There is some evidence to say that excess calcium intake can cause some degree of vascular calcification, but not the amount that we are prescribing for people for good bone health, not this 500 milligram once a day and all that.
Okay.
So there is actually a product of calcium and phosphorus. So if the calcium phosphorus product is more than 55,
okay,
then it goes calcium precipitation.
Okay.
So that calcium precipitation, so if the intake of calcium is actually exceeding the product of calcium phosphate, then there is precipitation in either the vascular bed or maybe even in the there is hypercalciuria and there is precipitation even in the urinary tract. So till we don't overdo it, then we are safe, and there is not really the so-called myth that your normal daily calcium intake will get precipitated. And the calcium scoring that we assess in the CT NGOs is basically the senile or atherosclerotic plaques. It's not because of our dietary calcium intake.
Okay. My friend from Andhra, Krishna Priya, is asking, is the pressure pain in sitting posture a symptom of osteoporosis in geriatrics? Many people, when they travel in the flights and all that, when they sit for 3 hours or 4 hours, because the muscle mass in the buttocks is not that good, they get pain. Is it due to the osteoporosis, or it is what? It's what Krishna Priya is asking. Usha?
I don't know. I think it's just some cushion effect is not there.
It's more of the muscle mass is less, or the subacute fat is less. More of the thin people, maybe that is a long-standing sitting will cause the bone pains or bone pressure pains. Otherwise, a weak bone will have pain even when you press. Like just a simple touch or even a strong holding of the bone will cause pain if the bone is weak. It's more of an osteomalacic bone, osteomalacia bones which are painful. Osteoporosis or osteoporotic bones will break. They will not be painful actually.
Okay. Is PPI a risk factor for osteoporosis? After how much time can they be risky?
That madam already took the case.
Yes.
Risk factors. There are many theories. There is increased gastrin production, and interfering with calcium absorption, and at some particular level, what they can do to osteoblasts and osteoclasts and all that. So clearly, PPIs, can lead to bone loss and fractures. How long? I think there's no definite answer to that. But I think more than 3 months, if you're continuously going to use it, you'll have to think in terms of prophylactically giving them additional calcium, and then actually start looking for the bone loss.
In fact, PPI has got so many side effects. Individually, it varies from people to people. There are doctors that are taking PPA for the last 10 years, no problem. Only thing, when you do endoscopy, they have polyp. But in the books, there are so many side effects for PPA. But the best thing is to take 3 months and give a break, holiday for PPA, and then restart. And then on demand only you should take PPA, because PPA has got now so many risk factors. Okay, now coming to the other question, whether all postmenopausal women should undergo the test.
Yes.
All should take. Okay. And then coming to the treatment, Minal, you say oral and IV. Suppose somebody can take IV once a year. They need not take oral daily, no?
No, that is a perfect plan. If they can take once a year IV therapy, then there is nothing better than, because it's easy to remember, compliance is much higher, and the efficacy on the results are also much better. Zoledronic acid once a year, 5 milligrams IV. That is a very good approach, and that can be continued for up to 10 years.
Yeah, actually, all the oncologists for a breast cancer, they give some drug called letrozole and all that. They give once in 6 months 4 milligram IV. That's what my patients taking.
4 milligram, yeah. 4 milligram is not the dose for giving for osteoporosis.
I vaguely remember it is 4 milligram IV infusions. Once in 6 months they give. You said 5 milligrams. I don't know. I'll have to check.
It's when we are giving for osteoporosis, it is 5 milligrams once a year IV.
Okay. But our oncologist said once in 6 months. Okay. That's what, for all breast cancer, when they take letrozole, they say at least for 2 years you take. That's what they were saying. So if there is no other problem, then we can wait and then take. But orally definitely is useful. But compared to IV, oral is not that good. We always say oral iron is better if they can tolerate. Then only we give IV iron. So in this case, we don't say. We say IV treatment of the bisphosphonate is really better. We are sure of the effect, and especially patients who are taking anti-cancer drug, a sure way of getting is to give IV once in 6 months or once in a year, whatever you said. Okay. Is there any role of decadurabolin? No, those days when we were practicing, we are giving everyone anabolic steroid and with good protein. So is it useful nowadays when osteoporosis?
No.
Decadurabolin, have you used it, Usha?
No, sir. Short up.
Yeah.
It has no role, sir. It is actually the anabolic steroids, as you call them.
Okay. Then you are talking about teriparatide. Do you give routinely for all patients if the bisphosphonate is not useful? Can you try teriparatide?
We use teriparatide for proven osteoporotic patients, sir. It is used as a second-line therapy, and but they are used as a preferred drug if the woman is in the reproductive age group and plan. So not in secondary osteoporosis, I'm talking, not the senile osteoporosis. If it's a secondary osteoporosis and the woman is planning a pregnancy, maybe of the reproductive age group, then teriparatide we prefer over other molecules. Otherwise, in the senile osteoporosis, BMD proven, we do use teriparatide quite often. Microgram dosage, and it's an anabolic hormone basically. So we can bone rebuilding or bone strengthening can be taken up.
But teriparatide need not be given only for hyperparathyroidism. It can be given even for a normal parathyroid patient also, in your opinion.
Yeah, yeah, of course, it is not related to the status of hyperpara or hypopara. We are treating osteoporosis here. So we are giving it as a molecule for osteoporosis to treat proven osteoporosis with a T-score less than -2.5, already having a fracture, already had one fracture. So we are using teriparatide in such cases.
And what ages osteoporosis sets in males and females? Any difference between males and females? At what age this osteoporosis you have given two cases. Usha has given us a young person. You have given an older patient. So any particular cutoff age, after this age it won't come, or after this age, below this age, it won't come. Any such data?
Won't come. Osteoporosis is actually an ongoing bone loss process. It's just like ongoing any other disease. It's an ongoing bone loss with aging because of the increased life expectancy. Osteoporosis is coming to the surface more commonly. And women after menopause, they face a steep fall in the bone strength. So osteoporosis actually is fastened in women post-menopause. So especially suppose a young woman having undergone a hysterectomy will face osteoporosis at a younger age because her physiological age is behaving like a menopausal stage. But men face osteoporosis some 5 years later than if you compare a woman who has lived a normal life with no history of hysterectomy, normal menopause of a mean age of 51. So she might have start facing osteoporosis around 56 after 5 years of menopause. But men will face osteoporosis somewhere around, say, around 70. And with the increased life expectancy, maybe osteoporosis will be of the severe variety, the severe osteoporosis will be there.
And,
so there's
Usha,
nothing like not facing.
Yeah, Usha, do you advise post-menopausal women, for every woman, calcium supplement, or if they are well educated, if their nutrition is good, they need not take anything?
So ideally, everyone should take about 500. But if they tell me that they are particularly paying a lot of attention to their calcium content of their diet and making it a point to eat and drink a lot of dairy and all that, then it may not be necessary.
Okay. Calcium has got a long half-life. Whether it is necessary to give calcium every day or alternate days?
Recommend every day.
Rangarajan is asking. Okay. Is the idea?
I differ here. I really differ.
Yes.
Yeah, tell me. We like the difference only, please.
Yeah, because I think it is what with me. Calcium is to be, rather if we are planning to give more than 500 milligrams, we need to give it in parts. Rather, we cannot give it alternate day. I can't even give a bulk like 1 gram at one stat dosing. The body absorbs only 500, not more than 500 milligram at one go. So you have to actually give it either 8 hourly, or at times you have to give it 12 hourly, twice BD dosing if you are planning to give more than 500 milligrams.
Usha, do you agree with Minal?
500 once a day is what I give. But if they need more than that, I totally agree with Minal that you have to split it and give it. It's also better tolerated. And taking it once in 2 days and 3 days longer won't really be effective.
No, you remember in those days, for children, they give calcium in the shell call and small pupper, like a toffee, they used to chew. Every child will come and take it. Is it advisable to take calcium even like this for children when they have no problem?
No. See, children, their bones are growing, so it's a different kind of growth as opposed to the kind that the adults have. So for children, calcium nutrition and vitamin D nutrition is extremely important, and taking into account their nutrition, they have to be supplemented.
Okay. Minal, for you one question. ILD asthma patients who are on steroid inhalers, do you advise any preventive measures for them? Regular steroid inhalers.
They should be treated, yes, sir. They should be treated just as we discussed the case of steroid-induced osteoporosis. So even the inhalational route, ultimately the steroids do get absorbed. And especially the case of ILD who are supposed to be with steroids for the remaining of their lives. So they should definitely be given the benefit of calcium and vitamin D primary prevention. They should also undergo BMD scoring. And if it comes to have a T-score of less than 0.5, then they should also be treated with bisphosphonates. And if they have a fracture, then in that case, they should be treated with teriparatide.
I think Meena Ajbani, I hope you understand the Meenal's answer, because it was your question. Then can saps of long bone fractures due to osteoporosis? Humayun Hassan. Long bone, saps of long bone fracture due to osteoporosis.
Definitely we can have, but one of the things we want to keep in mind is, see, osteoporosis is more like a global phenomenon, meaning the whole body, all the bones get thinner. Certain areas are at greater risk for fracture, like compression fracture of the spine, or hip fracture because of the hip axis length and what happens when you fall. And earlier on in life, when people fall and their reflexes are good, they will stretch their hand. So the Colles fracture is more. So here Colles fracture, then as they get older, vertebral and then hip fracture. So that is the sequence in which they have fracture. But you can have tibia, fibula, femur. Always keep in mind atypical fractures. There's the atypical fractures, especially with use of bisphosphonates, has come in, and that is something we want to keep in mind in long bones like humerus and femur.
Usha, again, a terminology clash. You said atypical fracture. What is the difference between atypical fracture and pathological fracture?
Pathological fracture is when like a metastasis or something has gone to the bone or anywhere, any part of the body. The metastasis can go and you can have a pathological fracture. Whereas atypical fracture is more like a fracture in the mid shaft or of long bones, which we are seeing as a consequence of bisphosphonates.
Excellent, excellent, Usha. I'm very happy. What about bone turnover markers? What is their importance in the management of osteoporosis?
So
bone turnover markers.
we have both resorption markers and P1NP, which is a bone, which we use with periparatite. The thing is, we thought they were useful only in the past for monitoring response to treatment, studying compliance and all that. But now with a lot of what we call combination therapies and sequential therapies, you give one, then you give the next. You give a resorption therapy, anti-resorption, then an anabolic, or an anabolic and then an anti-resorptive. Now that we are doing all the sequential therapy, we are studying the bone markers before starting the other drug. So it's become.
That's very good. Minal, think about heparin induced osteoporosis. Humayun Hassan.
Yeah, so this is the most common cause of the secondary osteoporosis, hyperthyroidism, hyperparathyroidism, and even heparin. They do cause osteoporosis, and that is the same method. The bone turnover is increased, the osteoclast, the resorptive activity is increased in case of hyperthyroidism actually. So we do have bone weakness or the bone fractures. The bones are easily fractured in case of hyperthyroidism. We do treat them the same method.
Okay, very good. Bisphosphonate can be used up to what EGFR or CCT?
So ideally, if there is a CKD, definitely EGFR below 60. That's when I think denosumab is a good option. It's an alternative for people with CKD.
Okay. When you on bisphosphonate, is there any period where you can stop, or will you continue bisphosphonate for osteoporosis? Ambujam is asking, Rangarajan. How long to give bisphosphonate? Should there be any drug-free period? After how many years?
As Minal correctly pointed out, we have 10-year data, but ideally, I think now we prefer after 5 years or so to give a drug holiday, reassess the patient. Because what happens when you give an anti-resorptive for a long time, it becomes a very adynamic, inactive bone. We are shutting down everything. So when you shut down resorption, you also shut down bone formation. See, the bone forming cells and bone resorbing cells are constantly talking to each other. You shut one down, you shut the other one also down. So you don't want to lose that bone forming cells. So you can give them a holiday, wait for things to wake up again, and then choose which drug you want to give. That's why I mentioned now we have gone more into this sequential therapy and combination.
Okay. If the patient has got compression fracture in T12, is it necessary to take BMD before starting bisphosphonate, or can we start empirically?
I would.
Yeah, ma'am.
Go ahead, Meena.
So actually, ma'am, compression fracture is itself one of the vertebral fractures that we are talking of. So since last 1.5 hours maybe, that what we are talking is an osteoporotic fracture or the loss of height that we commonly assess, or we see the humping out of the back. Maybe there are many parameters where we measure the distance from the wall or the height, decreasing height, and compression fracture markers. So yes, on the basis of clinical markers, also you can start teriparatide. But if you want to look at the status of other bones other than the central spinal BMD, you want to look at peripheral BMDs also, then you can make the patient undergo a BMD, because there can be at times some other cause of compression fracture, may not be osteoporotic. It can be METS, as madam said. It can be a diseased bone, maybe. Are we missing out on something else? So we can go for a BMD as a protocol.
Okay. Because why this question is asked, because when you have a T12 fracture, getting a bone scan, all compulsome, taking him to the institution. So that's why he's asking empirically whether we can start. Okay, you answered it well, Minal. Another interesting question, Usha, I think you should answer. Yogesh, do circus artists get osteoporosis later in life in view of higher muscle mass? I think paradoxical. You said higher muscle mass means less osteoporosis, but this Yogesh is asking circus, all the circus artists, they have a good muscle mass. So do they get osteoporosis later in the life? We have not done any study on circus artists. Maybe you can,
another one. See, people like, for example, sumo wrestlers, right?
Yeah.
Wrestlers are huge.
Yes.
Stop doing the fight, the wrestling, then suddenly they even the same weight. Now they become diabetic.
Okay.
So like that, I'm just thinking from their high physical activity, if they stop it suddenly, will something happen to their muscle? And it's a very interesting thing. I'll go look it up.
Yeah, because Yogi my friend is asking for imaginary question. I think he's watching a lot of circus. That's why he was interested to ask this question. Thanks, Yogi.
What I believe, ma'am.
Go ahead, Meena.
Hello.
Go ahead.
So
go ahead.
what I was thinking when I read the question in the chat box, what I was actually thinking, ma'am, that the circus artists have a more flexibility. So that must be preventing the fractures actually. Maybe the bones are osteoporotic or not in later life. I am not very sure, but the flexibility must be given edge over fractures.
Unless they fall off the thing.
Okay. Another interesting question again, Usha. Ozone. Nowadays, people give ozone for so many things. Even for cancer, they give treatment. Believe me, in Chennai, there are 2-3 centers that are doing very well. I mean, not very well. They are doing unnecessary publicity, and people go there, take ozone injection, and they feel better with the ozone injection IV. The ozone is good for osteoarthrosis, osteoporosis.
Not osteoporosis. It's been tried for osteoarthritis. So what they do is they give, and there are very nice randomized studies they looked at comparing glucosamine and celecoxib on one hand, and ozone and chondroitin sulfate and glucosamine and on another hand, and found benefit with ozone intra-articular injection. But
okay.
Those are all, I think, still I don't want to say experimental, but still some sort of exotic treatments going on.
Yeah, in fact, Usha, there are 2-3 good centers with all facilities, 5-star facilities in Coimbatore and Pollachi. They give ozone injection for cancer treatment, for well-being, for rejuvenation. People go there 2 weeks, stay there, get ozone every day, and they say they get better, they get rejuvenated. I don't know, because they show also some papers how ozone can cure cancers. So that is again in the pipeline. If you come next time, in Kannagi's place, Usha, there is a big hospital they are doing ozone therapy only. And somebody from Chennai comes every week, and then they do ozone therapy. So some interesting, things are happening. Now, the last question for Minal. If at all somebody has to take prophylactic dose for preventing osteoporosis, what would you suggest? Vitamin D and what dose and how long?
So prevention prophylaxis is only calcium and vitamin D so far. We are not giving bisphosphonates or teriparatide as prophylactic therapies. They're only using the calcium and vitamin D. And doses we have already discussed. The recommendations are the 1 gram or about 1200 milligrams of calcium per day, out of which, as madam said, half should come through your nutrition and half can be taken as a supplements. And similarly for vitamin D, it is 800 IU per day, and we have no nutritional source, so it has to come through your supplements.
Okay. Usha, can we prevent osteoarthritis by giving some drugs? Can we postpone at least?
So,
Dr. Subhas Mittal is asking.
the only thing that has worked is this glucosamine chondroitin sulfate. I'm not saying it's for, obviously it's only for people with established osteoarthritis. The only prevention for it is really keeping the weight down. Would be the big risk factor. So keeping the weight down is really important. And also people who in childhood and young years and adult years involved in a lot of contact sports, they have some wear and tear and all that. But it's just keeping the weight down is the number one thing I think for prevention of osteoarthritis.
And Kannan Pugalindi, Usha from Chennai, the sports medicine specialist. He says, certain exercise can, prevent, postpone the osteoarthritis, and he give particular exercise for particular joint, and the results are very good. So he is very successful in treating, postponing osteoarthritis in many elderly persons. Exercise as a role, he says. Okay, I think we'll come to end because there are another 10 questions more. Already it's 10:40. So we'll wind up. Before we wind up, one question, Usha: is there any antihypertensive which can cause osteoporosis? Any particular antihypertensive?
I can't off the top of my head think of it.
Okay.
The one thing I can think of is like diuretics are supposed to keep more calcium inside.
Not all diuretics.
Thiazides.
Yes. Yeah. Okay. Because Minal, you are talking about some relaxipin, no? It's some drug. What is that drug? You are talking some
Selective.
relax. Minal? You unmute, Minal. Please unmute.
Yes, sir. You are talking about the raloxifene.
Yes, relaxipin.
Raloxifene, as Madam told, we are not.
Yeah, go ahead.
The raloxifene and the tamoxifen molecules are the SERMs. We are not using them very frequently for osteoporosis actually.
Sir, I just wanted to say,
Selective,
Yeah, Usha.
osteoporosis management, the yardstick is only to prevent stiff fracture. So many of these drugs, even if they work on vertebral fractures, if they have not prevented hip fracture, then they are not approved for therapy.
Okay. Because I saw one of the prescriptions from one of my UK friends. They were showing relaxipin, and they say that drug has got something in the cardiovascular health also, something like that. So that's why I was interested to know.
Unfortunately, in that study, it's called raloxifene.
Raloxifene is ideally used in post.
It's called the Root study. Raloxifene.
More.
And the study, they've actually slight increased risk of ischemic stroke. So after that, the drug itself has become, very selective use only in people who have got, vertebral osteoporosis and breast cancer.
Okay.
It's like tamoxifen.
Yes.
So.
And the word about the monoclonal antibody, Minal? Monoclonal antibody? Minal? Dr. Minal? Minal, are you there?
Yeah, yes, sir.
Yeah.
Hello?
What about the monoclonal antibody? You were mentioning some monoclonal antibody.
Monoclonal antibody is denosumab only, that we are using it once in 6 months. It's another injectable therapy that we are using it once in 6 months.
Okay. Effect?
It is another very good molecule, another anabolic molecule. It is showing increased bone strength. It has got clinically efficacy, is proven efficacy. Okay. And it has been available recently in the Indian market actually.
Okay, very good. Very nice. Excellent, Minal. Now I think we'll conclude one final message from each the eminent specialist, a drive home message for all our audience. Usha, first from you. Oh, sorry. No. First, Minal, because Minal said you will be the last person. Okay, Minal, tell me, Minal.
So I would reiterate what Madam said. For especially the diabetic population and osteoporosis for everyone, A for A1C control, B for BMI control, C for cut down your carbs, D for your diet, protein and calcium and vitamin D intake, and E for exercise daily. So A, B, C, D, E. That is the crux of this entire thing.
Minal, you are a specialist in the holy, because we don't sell holy Usha. So tell me for the holy message, any holy message for diabetic patients, because this time you written an article on the holy. Any message you want to give for holy?
Play with safe and natural colors. Keep your sweet tooth satisfied with fruit intake rather than the sugar-coated sweets, and stay sweet-tongued and stay healthy and stay happy. And play holy.
Yeah, actually, Usha, 18th is the Holi. We don't celebrate Holi in that way, but in North, they celebrate so much. In fact, I wanted to have this program on 18th. Minal said, no, because it's a holy day. It's not holiday, it's a holy day. I said, okay, then I have it on 16th. So thanks, Minal. Now, Usha, your final message and your final word. You will be the final person to talk about the whole thing.
All the points we have discussed today are very important. That we keep thinking of bone health, because anybody, we do so much for their other aspects of health, and if we had ignored this, and if they fell down and either their quality of life became very bad, I think that would be inexcusable. And when it is a preventable condition and treatable condition, so we must keep bone health from the childhood. Osteoporosis is a geriatric condition with pediatric origin. So good nutrition from childhood, lots of sun exposure, lot of physical activity, and postmenopausal good calcium and vitamin D intake, bone density from screening from age 55, at least crack scoring, and appropriate therapies from then on.
Very good. Excellent. Thank you, Usha. Thank you, Minal, for the excellent deliberation and debates on various questions. Really, it was very interesting, and then people would have learned so many things. And as you rightly said, prevention is the key, and you will start from the childhood. And then none of us go because of especially in Rajasthan, if you go in sun, you will definitely, get all sorts of problems, especially during summer. But you said 11 a.m. to 3 p.m. At least 10 minutes if you go, you will get vitamin D instead of taking vitamin D orally. That's a very good drug. That was the treatment for TB, tuberculosis also in earlier days. The best treatment they are giving in the early days, you can see even the Chicago ward, they have shown it be in the sunlight. So they were treating TB with sunlight. So sunlight is very good. So it's a good sunlight which will prevent so many problems, even osteoporosis. So thank you, ladies and gentlemen, for listening to us. This webinar is in the website. So those who missed can see it's in the YouTube also. And looking forward to you, Usha and Minal, for some more interactions. And I'm very happy to inform all of you, Dr. Usha Sriram is going to organize one Women's Health on April 1st and April 2nd. And April 3rd. Okay. So on behalf of Usha, we invite all of you to participate. And Usha hopefully will involve me and Minal also in that Women's Health, because always Usha is very fond of doing women's and Diswas. That was her, association. That she's doing lot of work on this, and I'm very happy. So many people. I think there are 728 people who have joined today. So I request all of them to join, even for the April program for Women's Health, and we'll send you the invitation. And hopefully the Doc Plexus will help us to promote this for that program also. Thank you once again, Usha. Thank you, Minal, for in a short time you did a good job, and we look forward to meet you in other subsequent meetings. Okay, thank you.
Thank you, ma'am. Thank you, sir. Good night, sir.
Good night.
Thank you.